Good evening. I would like to welcome you to the American Society of Podiatric Surgeons Virtual Education Series. Thank you for joining us. I am Dr. Ashley Corvus, Chair of ASPS and your host this evening. On behalf of the Education Committee and the Board of Directors, we are excited to present to you this evening a presentation on remote patient monitoring made simple, coding, compliance, and documentation guidelines to help your practice and your patients. Next slide, please. This live webinar is approved for one continuing education contact hour. Please complete the survey at the end of this program, and a PDF copy of your certificate will be emailed to you within 3 to 5 business days. This presentation will be available in the ASPS on-demand library for our members. If you are not a member of ASPS, we invite you to join and take advantage of more opportunities for fantastic education and benefits. Next slide, please. If you have questions or comments, please use the questions area located in your slide control panel. We will have a short Q&A session after the presentation. Please note, to receive 1 hour of credit, we need you to stay online with us tonight for 60 minutes, 1 full hour. You must be logged into a laptop, tablet, or phone using a web browser or the GoToMeeting app, and must be able to view the slides to receive credit. Participating by dialing the phone number only does not qualify for credit. We invite you to stay for the duration of the Q&A session. However, once you have been online for 60 minutes, you do not need to stay for the full duration if your questions or comments have been answered. Thank you again for joining us this evening. Next slide, please. I now have the distinct pleasure of introducing tonight's moderator for our webinar, Dr. Melissa Lockwood. She's a board member of ASPS, and she will introduce tonight's speakers as well. Thank you.
Thank you, Dr. Corvus. And next slide, please. I have the distinct pleasure of introducing tonight's presenters, both friends of mine, Dr. David Yeager and Dr. Jeff Lehrman. Dr. Yeager is a board-certified podiatrist practicing at Morrison Community Hospital Family Care Clinic in Morrison, Illinois. He's a fellow of the American College of Foot and Ankle Surgeons, a fellow and the education chair for the American Society of Podiatric Surgeons. He's a past president of the Illinois Podiatric Medical Association and a past board member of the American Board of Podiatric Medicine. Dr. Lehrman is a podiatrist in private practice in Fort Collins, Colorado, and he operates Lehrman Consulting, LLC. He's a diplomate of the American Board of Foot and Ankle Surgery, a fellow of the American Society of Podiatric Surgeons, and he's been honored with the designation of Master by the American Professional Sound Care Association. Dr. Lehrman is also a certified professional coder, and in his role as a consultant to the APMA Health Policy and Practice Department, he serves as the APMA staff liaison to the AMA CPT editorial panel, where CPT codes are created, deleted, and modified. He is on the editorial advisory board of the journal Wounds and has taught both nationally and internationally on wound-related issues. I welcome you both, and I will let Dr. Yeager take it away.
Thank you, Dr. Lockwood, for those kind words, and really want to take the opportunity to thank you all this evening for taking time out from your practices, your families, in this unprecedented time in which we're living in right now. And I especially want to give a shout out and a thank to Orpyx, sensory insoles. Without them, and this is the second year that ASPS has been able to provide this phenomenal education for all of you free of charge. And we really want to thank them, and without their support, there's no way that we can even do this at any time. So thanks again, Orpyx, for your help. And we look forward, and I look forward to working with my friend tonight and presenting some very cool, interesting technology regarding our fight with the inevitable diabetic foot ulceration. So next slide, please. So full disclosure, I'm a consultant for Sweet Bio, Crossroads Medical, and Envision Medical. That's Dr. Lehrman's disclosures as well. Next slide.
And we want to share, I think you've heard us say this before, anytime we share CPT codes, it's important to share that CPT is property of the American Medical Association. They license those CPT codes, and the reference for the CPT codes that will be included at the tail end of this presentation are the 2021 CPT professional book. Dr. Yeager and I have some goals that we want to accomplish in the next 50 minutes or so. The first goal will be to define remote patient monitoring and really explain what it is, and for our purposes, explain how it can play a significant role in podiatric practices, and how our remote monitoring of physiologic parameters can help our patients, help our community, and also help us. And the pathology that we will really focus on, which Dr. Yeager already mentioned, is diabetic foot ulcers, and how we can do a better job and serve our communities better than we currently are by embracing remote physiologic monitoring to decrease the incidence of this plague, which affects way too many of our patients and our community. So we will go through the need for this, starting with establishing the morbidity and mortality and just how awful this plague of diabetic foot ulcers is, why we need to do a better job of prevention, how we can embrace remote physiologic monitoring to practice prevention, and then hopefully, after we've gotten you excited about that, talk about the coding and compliance that accompanies this so that you can implement this all the way around into your practices if you haven't already. And having laid the foundation of those goals that we want to accomplish, I'll transition back to Dr. Yeager to get us started on the discussion of the diabetic foot ulcers that we all deal with way too much.
Thank you, Dr. Lehrman. I really appreciate those. And you hit it right on the head. This is a entity that we need to address each and every day in our practices. And so tonight what we're going to talk about is remote patient monitoring for DFU prevention. Okay, prevention is the key. And really the technology that's coming out there is not only exciting, it's cutting edge, but what I like about it the most is that it interacts the patient to be more accountable for their health. A lot of times what happens with these diabetes and these diabetic patients is they really don't understand what's happening. They don't care. They lose interest in their health. So what we want to do with this remote patient monitoring is we want to avoid high costs of healthcare. We want to avoid the patient going to the emergency room, ending up with an amputation. And how many times do we have those patients that say, you know, I went to Dr. Yeager, he cut a little bit more, and then he cut a little bit more, then he took my foot, then he took my leg, okay? We need to stop that. We have to stop that conversation, okay? And so RPM, a remote patient monitoring, we're going to allude to in the discussion here, is absolutely cutting edge and involving those patients for accountability and take some of the responsibility off of us and onto them, which is about time, amen, brother, that we need to do this, okay? So at the beginning, like Dr. Lehrman was alluding to, we're going to talk a little bit about diabetes and its repercussions along the economy, along any of these things, and it's touching us. Each and every one of us know a patient that has diabetic or a family member or one of us that has it, okay? And the numbers that are out there are truly astounding. 70% of people with diabetes develop peripheral neuropathy, okay? 1 in 3 North Americans are pre-diabetic or diabetic. Now, those are the ones that are diagnosed, okay? How many millions are out there that aren't even diagnosed right now? That equates to 136 million people that are diagnosed. Undermanaged diabetic peripheral neuropathy, number 1 cause of non-traumatic lower limb amputation. Number 1, 25% of these people with diabetes, 25% develop diabetes, foot ulcer over their lifetime. We can do better. You know what that equates to? 1.7 million DFUs a year. We can do better. We're America. We can do way better than that, okay? What are the economic burden of patients with DFUs? Astounding, okay? A study by Dr. Margolis in economic burden of diabetic foot disease, 1.7 million diabetic foot ulcerations per year, 1.7. 14 outpatient facility visits per year, that's the average. 1.5 hospitalizations, okay? What that equates to in real numbers, between $15,000 to $70,000 it costs. 15 to 70,000. Now let's look at in real numbers. How about we break that down and we are able to cut that in half? How many billions of dollars are we saving? Okay, I'll take half. I'll take 10% for crying out loud. Okay, let's not overcheat, but let's do the best that we can. Next slide, please. So this is a great slide. This is one of my favorite slides in the presentation, besides some of the other interesting stuff later on. Dr. Armstrong does a fantastic job with his crew at USC. And what he did, he took the mortality rates with patients with DFU and compared it to cancer. Okay, in 2020, he published this. What's really cool about this, you guys, and not so cool, the 5-year mortality rate with patients with Charcot, those are the patients that have the really, really bad, incredibly bad feet that break down a great percent of the time. And DFU was 29 and 30.5%. Minor and major amputations were 46.2% and 56.6%. Okay. This is compared to breast cancer, which is 9%, 80% for lung cancer, and the 5-year pooled mortality for all reported cancer was 31%. Okay, that's astounding. Now let's talk about some of the costs. All right, cost in general for diabetes in general is 237 billion. That's it with a B, billion in 2017. That's 4 years ago almost, right? Up to a third of direct costs care of diabetes attributed to lower extremity, which equates to about 78 billion. 80 billion costs for cancer alone in 2015. So the lower extremity is 78, just the lower extremity, 78 billion. Cancer, 2015 was 80 billion. Okay, we have to stop this cascade. We have to stop this resulting in amputations. We have to stop resulting of American people and people throughout the world passing away from this mortality. Next slide, please. So current treatment paradigm, 49% recurrence rate in the first year, 68% recurrence rate within 5 years. Okay, let's break this down a little bit. Okay, this is depressing in terms of we work so hard. Okay, how many can you think of? You've got a patient that comes in, they're nervous, or they've got a callus that we debride and we take it down. What's underneath? Okay, you've got a pus pocket, you have an ulceration now, right? Okay, it's certainly not a unique situation. It reopens. Okay, in fact, in the first year, 49% of people reopen within the first year, 68% within 5 years. Because I tell patients, hey, listen, we're not done yet. Okay, we also have to address the biomechanical issues that are addressing this, and we can touch upon that a little bit later on in terms of pressure points, etc., and how we alert the patients, hey, you got to move. You're spending too much time on that area. You're gonna end up with an ulceration. By year 10, almost all those patients have one additional ulceration of the 68%. It's amazing. Okay, so we have to change kind of our way of telling patients, hey, listen, you're healed. No, you're not healed. You're just in remission. Okay, what I mean by that is biomechanically, you're still going to have the problems that we need to do this. So we need to off-weight that area. We need to identify the pressure places that we need to take pressure off of that area. Okay, just because you heal now and you dodge that bullet doesn't mean within a year. I mean, these statistics clearly state that it's going to happen. It could happen. Okay, so we need to change your attitude. We need to change the way that you actually view your ulceration and be more proactive itself. Okay, fortunately, Center for Medicaid Service or Medicare Services, excuse me, has identified the fact that this is a distinct problem, that it's not healed, that it's in remission, and have acted accordingly to help us in this battle. Next slide, please.
So Dr. Yeager did a nice job here of setting the stage and establishing how awful diabetic foot ulcers are. And really, most of what we said there was why they're so terrible for the patient and why we should be motivated to embrace prevention, why we should want to prevent these, and that is to provide better care, to better serve our communities, to be a good doctor, to fulfill our oath. And that's good, and that should be enough to motivate us to want to embrace prevention. But if we must, we can look at this from a selfish reason also, in addition to those selfless service reasons. And maybe you're thinking, I don't need to. I'm sold. I know I need to do a better job of prevention, but doesn't hurt to add this in. The lesson that our relationship with our third-party payers is changing. It's taken a long time, but it is changing, and we are slowly shifting from a fee-for-service model to a model that tracks quality and costs attributed to the patients that we take care of. Tracks these things, publicly reports these things, and then uses the quality of our care and the costs associated with the care that we provide to influence our fee schedule. So that if our quality is good and the costs associated with the care that we provide are low, that has a positive impact on our fee schedule. If our outcomes are poor and the costs associated with the patients that we take care of are high, that has a negative impact on our fee schedule. This is here right now in the form of MIPS. And if you've been following MIPS, we're now into, believe it or not, our 5th year of this. The one category that continues to increase in weight is the cost category. This year, the weight of the cost category went from 15% to 20%. So 20% of our MIPS score comes from that cost category. And if you think, how can I, as a podiatrist, keep costs down? Dr. Yeager just told us about the billions of dollars that are spent in the care of diabetic foot ulcers. So if we can prevent them, if we can prevent some of them, that results in a tremendous decrease in the costs associated with the care that we provide. This is not some far off thing that's coming way down the road. This is here today, right now, in the form of MIPS, where our 2021 MIPS score, what we're doing right now, is going to impact our 2023 fee schedule with a swing of anywhere from -9% to +9%. If you go back to 5 years ago when this first started, if you were somebody that said, I don't care about the 4%, let them hit me with the 4%, so I don't have to worry about this nonsense, your approach might change, knowing the degree to which the stakes have raised, and now knowing that 9% of our fee schedule is on the line. And that's an 18% swing from -9 to, if it were to go as high as +9. Point being, we should be concerned about prevention and decreasing costs right now for our patients, but also for ourselves as it relates to this. So how can we do that? How can we embrace prevention? How can we decrease costs? How can we improve the quality associated with the patients that we take care of, improve the quality of our care? Preventing diabetic foot ulcers. Dr. Yeager gave us the statistics. All too often, by the time it opens up, it's too late. Our healing rates stink. The mortality rate is high. The recurrence rate is high. The costs are high. Waiting for it to open and then trying to heal it all too often fails. So how can we prevent them? How can we stop them from happening? There's lots of stuff we can do. A very powerful thing we can do is to monitor the things that we know are signs that an ulcer is developing. Catch it before it happens. And this is a combination of things, not just one of these things. What we're going to focus on tonight is using a system to monitor pressure, temperature, and adherence. All three of those. So we like to say measure what matters, not just measure what's easy or measure what the thing you bought measures. Measure what we care about. Measure what peer-reviewed literature tells us matters when it comes to picking up the development of a diabetic foot ulcer before it opens up. And again, that's all three of these things. We know that pressure is the most important as far as predicting where an ulcer is going to develop. Temperature is typically a late stage indicator, but still of interest to us. And then adherence. 2 reasons. It tells us if the patient's using it, right? Dr. Yeager alluded to engaging the patient, getting them to care about what's going on and maybe motivating them a bit if they know that we know whether they're wearing it or not. And it gives us their activity level. How much time are they spending on their feet? How much walking are they doing? And again, we can look at the different parameters that we are assessing. It's important to note that temperature is a late stage indicator. I'm going to repeat that. Temperature alone, temperature is a late stage indicator. All too often, by the time we pick up that increased temperature, it's too late. So it's of interest, but the literature suggests it's only of interest when you combine it with the other 2 parameters of pressure and activity in the form of adherence. What we really want to know is where is that spot that's taking on too much pressure. And by monitoring all three of these things, temperature, pressure, and activity with the adherence, it gives us the information we need to really have what we need to try to prevent these diabetic foot ulcers. And Dr. Yeager is going to comment a little bit more on the pressure factor of this and what can happen when there is too much pressure.
Thanks, Dr. Lehrman. I really appreciate it. This is a slide that cannot be ignored. And, as little as 35 millimeters pressure is it's enough to break down. It's enough to cause, ischemia, tissue death, and it's essentially ulceration. And once we get to that point, like Dr. Lehrman alluded to, there's really no turning back. Okay. Now we have a headache on our hands. Now we have a situation where the patient says, "Oh my gosh, what do I do now?" And that opens up a whole bag of problems in terms of, I tell patients an open wound is a chance for infection. Infection leads to hospitalization, amputation, etc. So inevitably, when I have conversations with my diabetic patients when I'm going to the OR and unfortunately we have to do an amputation, you know what I tell them? This is the last time we're going to go down this hallway, right? You know what they say 100% of the time? Yep. Okay. What they say 3 months ago? I don't know what happened. 3 months after the surgery, I don't know what happened, Dr. Yeager. Okay. You know what happened is pressure. You know what happened is the idea that you didn't understand that you were having pain. Now you have an ulceration, tissue ischemia. It's a problem. So next slide, please. Like I alluded to, we can talk to we're blue in the face in terms of educating our patients, right? We can say, you know what, this is what we need to do. This is what you need to get your hemoglobin A1C in check. You need your albumin. You got to start taking better care of yourself, right? They have done studies and studies and studies with, right now in this study, 172 diabetic patients received the same amount of they received the same care, there was no significant difference in ulceration incidence 6 months and at 12 months. They had the same education. There was no indication of quality of life was seen, and in terms of that. So education didn't really affect improved mood or quality of life. They received the same exact care. So sometimes, next slide, please, that we have to look at the fact that we are dealing with patients that they're sitting in a foreign environment, okay? They hear 80%, but they hear 100%, they forget 80% of what their healthcare provider said, okay? So that leaves us 20% right off the get-go, okay? You're sitting there, and those providers in the audience, you know what we're talking about. They're looking at you, but the light's on, but nobody's home, right? Okay? So now they remember 20%. Of that 20% that they remember, only about 10% is even accurate, okay? So now we're dealing with that uphill climb with an ulceration. They don't understand what they're doing. And so I try to break it down as much as we can. What's easy enough, let's not get to that situation, okay? Let's get to the point where these patients empower themselves and take the ability to identify the ulceration, to avoid the ulceration, and take a more proactive stance in their health care. Next slide. So let's talk about diabetic foot ulceration and how a remote patient monitoring system works. Next slide. So when you're selecting an RPM system, there's a lot of things that you have to identify, and you have to really realize what is beneficial for you, your staff, and your practice. Okay. Physiological parameter must be within the practitioner's scope of practice. Know what you can do and what you can't do. It's pretty simple, right? Pressure adherence, step counts, and temperature. And I educate these patients, hey, listen, I'm gonna tell you right now, these insoles that you've got, this is what they're gonna monitor. And you know what? With my phone right here, I'm gonna get an alert, you're gonna get an alert, and you're gonna get a call from my nurse regarding what's gonna happen next, okay? So they go, wow, they're either blown away, they feel guilty, and or both, right? Which is great, okay? Staff requirements. The staff has to understand there is gonna be some monitoring, but it's extremely simple, okay? Each month I have my nurse just pull it up, let's see what they're doing, and we take it from there. Standard practice and workflows, I have them do that while I'm in surgery, keeps them busy, occupied, they stock the rooms, and then they get on this, okay? Accuracy of measurements, this is huge, okay? A lot of times what happens, and our best control against patients is what? The progress note, right? This gives us an opportunity to background information. Hey, listen, you said you're doing fine, right? And you said you're staying off your foot. Well, I have it right here, woohoo, okay, that you're not. okay, that we've called you multiple times. We put notes in your chart that are not accurate to what you're telling me. So do you want to start this conversation over? Inevitably, what happens is they, yeah, you know what, or a family member who's with them says, yeah, they're not doing it, okay? Patient considerations. Not everybody's going to be able to adapt this concept. And some of them you don't want to, but majority of people understand the fact is, hey, this is pretty cool. This is something I can use. Patient ease of use, it's right on their phone. Okay, you might have to take 5-10 minutes to discuss it with them, but it's as easy as stepping in a box, send it away, and then we actually are able to identify the pressure points and send them to them. It's phenomenal. Okay, Wi-Fi or cellular network connection, make sure they have got good of that. Cost of the patient, i.e. co-pays, identify that and identify those patients, because you don't ever want that phone call that says, you know what, I didn't know I was going to do this, right? Or going back to the 10% that they actually really understand, make sure that they understand that, okay? And make sure they have a consent form that's been signed that allows you through the cloud to identify this information and where the temperature, where the adherence, and where the pressure points are, so we can identify this. So we got to have that consent form in there. Next slide, please. So reduce the risk of diabetic alterations by providing the patient with a step count. That's awesome. Okay. Real-time audio-visual alerts of plantar pressure may cause tissue damage, and providing us as practitioners real-world pressure, adherence, step count, and temperature data. It's all in one. Okay. Now look at that's an example of an insole in the left-hand corner there. You can see it's not very thick. There's not a lot of diameter there, but it actually enabled us to now have a powerful tool in our armament against these diabetic foot ulcerations for these patients. Next slide, please. So let's talk about user flow, okay? Patient gets the insoles. I tell patients, hey, take it easy for a little bit, get to familiarize yourself with the technology, put it in your shoes, make sure that you're charging them, okay? They have a charger that is extremely easy, or any charger that you might use, you're gonna have, it's very easy to use. So where's the remote patient monitoring the insoles? Patient receives alerts based on the sensor data, modifies the behavior, okay? Patient, that's key, patient does, all right? The data then is uploaded to the cloud, and then the data is monitored by the dashboard, healthcare provider, and then CPT eligible, like Dr. Lehrman's going to allude to, and he's touched upon a little bit later on. Next slide, please. So let's talk about the stack, okay? When I say the stack, you're going to be surprised when you get your hands on these how thin they really are. The last thing we want patients to do is to shove these in, or shove an insole in a shoe or a diabetic shoe that's too thick or it's too high, that's going to cause the patient to have problems later on and cause ulcerations maybe on the dorsal aspect of the foot. These are extremely thin, and it also has a wireless charger as well, so it enables the patient to take some time to charge it, and they can drop it right in their boots at night. It's very, very simple, especially if they're working in an environment like that. So next slide, please. So this is what the patient's actually going to see when they pull up their alert. And what's interesting is that you can see that they identify the pressure points, and you can see that it's a live pressure map which shows the foot motion and distribution of the pressure itself, which is very, very cool. And then what I have is the patient stand there and say, hey, listen, can you see? And it's interesting because I have a real time, and I can tell the patients, and you can see they're blown away. So it enables us to have a little bit of power and a little bit of ability to understand, hey, you got to do what you got to do in terms of staying off this foot. Next slide. So the real-time alerts. So what happens? Empower the immediate behavior for the patient to get involved. So we have the patient walk for a couple minutes while viewing the affected region. Okay? We then have the patient take and sit down for about 2 minutes and taking pressure off their feet. One thing too, one caveat is make sure that the shoelaces are not too tight, because we don't want anything to affect that or put unnecessary pressure that's really not accurate. So check the footwear, tight laces, objects, rocks. You'd be surprised how many rocks that I have found with shoes that cause ulcerations. Take it out. And what's nice is we've really never had that technology before to identify rocks and foreign bodies and these kind of things in these patients' shoes. But these patients don't even feel. We're talking about slippers sometimes. It's easy to that. Put the insoles in the slippers. Okay, whatever you wear the most of your time, do it. So you're going to expect the foot for cuts, blisters, redness, swelling. What this equates to, and as we've got to number 4, this equates to an office visit, in my opinion. Okay, this equates to my nurse saying, hey, you know what? He's probably going to want to see you. okay? Because these high-risk patients with these high-risk limbs need to be seen immediately, and all my patients understand that with these diabetics. So once you reach to 3, maybe probably 4, okay, they're coming in because my nurses identified, we're gonna contact them, and we need to prevent the ulceration from getting to that point. So, and then the contact support's gonna, for further guidance, and we get a hold of them. Next slide, please. So what's really cool, and you know, you've seen real world information and real world a lot through the presentation. It's exactly what that is. It is cutting edge. It is right at your fingertips. And how many times and how many hours a week these phones monitor how much we're on our phones. We're on our phones all the time. Okay, gives you total alerts. It tells you what percentage of the time you've been in this pressure zone. It tells you how many steps that you've been taking. And what's nice for us is how many hours of use. Because how many times, you know, one thing I've learned as I'm heading into my 18th year, I know I look young, that that patients don't necessarily say the truth all the time. So this enabled us to have the ability to check exactly what they're saying, which is pretty nice, and actually guide us towards more of a treatment plan. And because maybe sometimes they're not able to wear these necessary hours for whatever reason. So let's work together and see that we need to do that. Next slide. So let's talk about really the real nitty gritty, and Dr. Lehrman was alluded to. So pressure, adherence, and step count, and temperature, okay? Pressure, pretty simple. Tells you the percent of the time the patient has been adherence and been off it, and get the kind of breakdown pressure of each area. Adherence shows how compliant, okay? Is the patient wearing the insoles? Are they wearing them how they're supposed to be wearing them, okay? In the shoes that they're supposed to be wearing. Temperature can be assessed by one of the 5 zones, which is very, very cool. And we'll touch upon that a little bit later on. What's interesting is it can measure the different 2 areas on each foot. Now, if the patient has only 1 foot, unfortunately, it can measure 2 different pressures on that 1 foot. But primarily, it measures the 2 different zones on each foot to measure a 2.2 degrees Celsius difference. Okay, you're probably saying to yourself, well, that's not a lot, right? But in the foot and the lower extremity and the plantar aspect of the foot, it's incredibly high. Because like we alluded to in that slide earlier, pressure, 2.2 degrees of Celsius difference can cause tissue breakdown, ischemia, and ulceration. So we want to make sure that we're not doing that. We stop that inflammatory process, and actually we'll check for a couple days too, which is very, very nice. Next slide. So this is what an RPM dashboard is going to look like, okay? Don't be intimidated by this. This is actually very, very cool technology. In the upper left-hand corner, we're going to talk about adherence, okay? Speeds it out real nicely, okay? How many hours per day are they wearing the insoles, okay? Second section is step count. This is something that the patients will really understand and really appreciate. And actually, I've had some patients kind of make it a goal to each day increase it, okay? I tell them, though, don't go crazy, because what happens is as you increase it a tremendous amount, you're going to increase the pressure, maybe. And by that, you could increase the problem or the possibility of having an ulceration. So I really don't want to do that. But you know what? Keep track of your steps, okay? And show your cardiologist, show your primary care physician what you're doing. Show them the technology that you're using, because I bet 99% of them are going to say, I really applaud you for using that, okay? And if they don't applaud you and they don't say to the patient, educate them what they're trying to do. We'll also talk about pressure too, and I alluded to in the slide before, a 2.2 degrees Celsius change in variance over a 2-day period can cause pressure to form, have problems, and cause ulceration. And so that is where we really intervene, and we really start saying, hey, your pressure's up on this side, your temperature is up, we need to really contact you, you need to sit down, you need to take a step onto that and get out of that area, okay? And also what's nice is that it shows you an activity log too as well. You know, we can really just expand on that, and you can actually tell the patients as much as you'd like to tell them and spend some time with them and say, I generally think that patients, maybe the first or second time we go over this, they're pretty excited. Third or fourth time, they're kind of saying, well, okay, well, you know, I know all of that. Tell me if I'm doing good or bad. And that's what they want, okay? You know, it's interesting that this has enabled us to give the power to really make sure that these patients stay in that pressure zone or safe pressure zone 60% of the time at the very least, okay? We need to make sure that these ulcerations don't reoccur. So next slide, please. let's talk about some of the clinical evidence, okay? Which I have to applaud Orpyx for this, for the simple reason we can't just throw these out there without some hard and fast. And so, you know, Dr. Bolton, Neil Reeves, all of these exceptionally brilliant people across the entire world actually were involved in this. And next slide, please. And their, you know, their random controlled study really showed the reduction in compared to control. Okay, they had an intervention group, received pressure sensing orthotics, and there was about 32 of them. The control group received the same orthotics, okay, but they weren't alerted and when it was elevated pressures were detected. Okay, the primary outcome was plantar foot ulceration recurrence within 18 months. Okay, this is interesting things. They received the same sensory technology, the same orthotics, except they weren't alerted what was going on. Next slide, please. So this is the money slide right here, okay? Results of the random control study showed that patients receiving the real-time alerts and wearing them at least about 4.5 hours per day, 86% reduction in ulceration, at least 4.5 hours a day. 86%. And then overall, 71% reduction in ulceration. Okay, that's awesome. Both groups, you know, showed statistically significant reduction in DFU. But one of the, like I alluded to in the slide before, it's interesting that they both received the insoles. They both received kind of the same information, however, no alerts. Okay, those alerts were able to reduce the 86% and the 71% in the ulceration in all patients, which is fantastic. So I really think that this enables us to have an opportunity to have a discussion with these patients in terms of, listen, this is a time for a paradigm change. This is a time for you to be involved. And this is a time for you to take control of your life and prevent these ulcerations, prevent amputations. And we all know the cardiac effects when we start doing below-knee amputations on these patients. We already alluded to that in terms of mortality. We have to stop this. Next slide. So unfortunately, you know, sometimes it boils down to politics and money, okay? And unfortunately, and fortunately for this matter, the cost effectiveness of these smart insoles preventing ulcer recurrence for diabetic foot remission, okay? This is a study by Najafi and Armstrong in 2018. They took 15 subjects with DFUs in the past 12 months. Data collected over 3 months, plantar pressures, device ulcers, alerts, and patient adherence. They were followed an additional 3 months without the sensory insole device, okay? Cost analysis. Decision tree models used to estimate clinical outcomes at 3 and 18 months, okay? The next slide is really what it boils down to in nuts and bolts in terms of cost analysis. So 83% short-term decrease in event occurrence, 77%, and that short-term decrease is over a 3-month period. Long-term decrease was 77% in 18 months, okay? 83% and 77% in 18 months. So we really didn't lose that much by extending it out an additional 15 months. And overall reduction of cost of care by 70%. Next slide, please. So cost-effective results is just a graphical representation of what we're dealing with here. I'd like to direct you to the right-hand side, which is interesting because the current standard of care, cost per event avoided, $1,367.47. Standard of care plus remote patient monitoring technology, $462.94. Okay. Current standard of care at 18 months, $53,134.94. Standard care plus remote patient monitoring, look at that, $6,702. Okay. You might say to yourself, wow, that's still a lot of money. And yes, it is. But compare 6,000 to 53,000, I'll take that all day. So I thank you. I'm going to turn it over at this point to Dr. Lehrman to talk about coding compliance and documentation.
We hope that we've gotten you excited about implementing this into your practice if you haven't already. And if you are excited and motivated to get this going in your practice, there's good news, and that is the third-party payers are also excited about this. I'd like to think they're excited about it because of the great outcomes and the first randomized control trial that Dr. Yeager went through with the 86% reduction. However, it's likely they are actually very excited about it because of the second randomized control trial that Dr. Yeager went through, which shows that it saves them money. So we'd like to think they are motivated to ensure the best possible care gets to their patients. We know that they are motivated to decrease their expenditures. So they have the same literature we do. They know that this saves them money and provides better care. So they want their beneficiaries to get this type of technology. They want us doing this. And it is no coincidence that over the last 2 years, we've seen introduction of CPT codes to represent the services that we've just described, increase in the payment associated with those CPT codes, and a broadening and expansion of the regulations that accompany utilization of those codes. So it is a rare situation in what we do that everybody wins. The patients get better care, better outcomes. The third-party payers are delighted because they're saving money. We've introduced a new service to our practice and are providing better care for our patients. Just like any other service that we provide, there are rules that need to be followed. We need to know which codes to use, when to use them, and what rules we need to follow. So having built the foundation that Dr. Yeager went through, now we'll give you the information that you need to actually implement this from a coding compliance and documentation perspective. If you're going to submit these CPT codes that represent the performance of remote monitoring of physiologic parameters, the first thing to consider is, which device am I going to use? Which device am I going to pick that's going to provide the feedback that I'm going to monitor? There are lots of options. Dr. Yeager and I use the example of the smart insoles as an option. There are other options for you to consider. We had a short period of time, we picked one as an example. When you choose that device, which is going to provide the physiologic parameter that you're going to monitor, there are a couple boxes that need to be checked. The first is it actually measuring a physiologic parameter? We all know the definition of physiology. Is it physiologic parameters that are being sent back? We use the example of the smart insoles that are giving us pressure, temperature, activity, steps, adherence, utilization. Obviously meeting the definition of physiologic parameters. And I'm making this point because this is a good deal. And I've been asked some silly questions like, and I know this is absurd, and I hope most of you roll your eyes when I say this, but like, if I get a pedometer out of a cereal box and the patient shows me how many steps they took, does that count? No, that doesn't count, right? It's got to be true physiologic parameters by the definition of physiology. The other thing to consider is, in doing what I do, I get the opportunity to communicate with medical directors at these third-party payers quite a bit, and it is clear that if they are going to recognize our submission of CPT codes that represent our monitoring of physiologic parameters, they want the device that's providing the feedback to itself be a covered device and to have a code. I'm going to repeat that because I feel like it was a really long sentence. If they're going to cover the CPT codes for our monitoring of feedback, they want the device that's providing the feedback to be covered and to have HCPCS coding. And in my silly example, the pedometer that's coming out of the cereal box, that's not covered. There's no code for that, right? And you will find other examples out there as you consider your options that also are not covered and don't have HCPCS coding. And I'd suggest that that should play a role in your selection of what device you're going to use to provide this type of feedback. These medical directors, and this is true of almost any service we provide, they want it to be medically necessary. They want there to be peer-reviewed, published literature that supports our provision of this service. Dr. Yeager shared with us the randomized controlled trial that shows this prevents ulcers and saves money. That's the type of data they're talking about. They want randomized controlled trials to support what we're doing. That can be said really of any service, most services that we provide. And lastly, the device that we choose should meet the FDA definition of a medical device. And this last one, this isn't even a payer thing. This comes from CPT. This is straight out of the CPT book. This was in the 2020 book, and it's in the 2021 book, that if we're going to submit these CPT codes for remote monitoring, the codes I'm about to go through with you, the device that's providing the feedback that we're monitoring should be a medical device meeting the FDA's definition of a medical device. That is a thing where the FDA defines what a medical device is. What we're using to provide the feedback should be a medical device. Now we can get into the coding. I mentioned that the product that's providing the feedback should itself have HCPCS coding. We used smart insoles as an example. Ideally, when you consider smart insoles, they have a PDAC assigned HCPCS code. I know most viewers probably don't know what the PDAC is, PDAC. That's a whole other explanation. The bottom line is when it comes to durable medical equipment, there is an official body that can make an official declaration that says this code goes with this branded device. So ideally, if you're using the smart insoles, they have been assigned that A5514 code. You have the option of you inventorying these insoles, bringing them into your practice, you dispensing them, and then you submitting the A5514. Now, not everybody wants to do that. Some people don't want to do DME through the office. Some people have had not great experience with the diabetic shoe program and don't want any part of it. Others are doing great with the diabetic shoe program. You just have to know how to check the boxes and get it all done. But you have the option to do it yourself. It is good to know there is another option. There are third-party entities that can collect all that paperwork for you that's affiliated with the diabetic shoe program and get those signatures from the other doctor and make sure it's all put together and let them take care of that for you. You can do it either way. If you're rolling with the diabetic shoe program and you're comfortable with it and you're doing great with A5514, which a lot of us are, you can do it yourself. You can also choose to outsource this with a third-party entity if you choose. So we've established the HCPCS codes for the product. If you're doing shoes along with it, there's code for the shoes as well. But for our purposes, we focused on the smart insoles, A5514 for those inserts. Now we can get into the CPT codes for our provision of remote physiologic monitoring. And there are going to be 3 steps to this. 3 steps. This is the first one. This code we submit when we dispense the device, set it up, and then teach the patient how to use it. So in our example, it was the smart insoles, the visit where we give it to the patient, get it all set up for them, and then teach them how to use it. There's a code for that, this CPT 99453, which we dispense when we provide that service. That service should, of course, like any other service we provide, be appropriately documented so that we document that we gave it to them and what setup we provided and what education we provided. Like, I did the programming and made sure it was communicating with the app that we had downloaded onto the patient's smartphone. And I showed the patient how to access the app. And I showed the patient what to do if they get an alert. And this is what the different alerts look like. And provided them education on how to communicate with me regarding these alerts, right? All the setup and the education that we perform at that visit should be documented. This we do once per episode. We give them the inserts. In our example, we teach them how to use it. We do the setup. We submit 99453. So that's a good start. Now, once we're rolling, we are also providing the patient with the transmission service. So this is something we are providing to the patients. Every month, they are getting this transmission that goes back and forth. I like to think of this as a hardware and software thing, just like our smartphones, where we buy our phone once, right? Now we got it. That's kind of the 99453. But then every month we have to pay for the service because we want stuff to come in and out of our phone. That's the 99454. So once they're rolling for 16 days, every 30 days that we provide that transmission service to the patient, we are submitting 99454. Every month we get to drop this code. That's a good thing. Now we have to do the most important part, which is to monitor the feedback. And we have a code for that as well. This is the third level. Don't get confused with the two. Let's just start with 99457 if you're looking at the slide. For every month that we spend 20 minutes or more monitoring this feedback and have at least one live interactive communication with the patient, we can submit 99457. For every month that we spend 20 minutes monitoring the feedback and have one live interactive communication with the patient, we submit 99457. If that is medically necessary and performed every month, then we submit that every month that that is performed. Now, you may be asking, well, what happens if I go over 20 minutes? What if there's a lot of data that needs to be monitored? We have an add-on code for each additional 20 minutes. So if we do 41 minutes, we have 99457 for the first 20 minutes and 99458 for each additional 20 minutes. And here's one of the changes that happened from year one to this program into year two of this program, which was so awesome. And that change was that CMS designated these codes that they could be provided under general supervision. Now we're talking about efficiency in the office. And when you heard me say every 20 minutes that you spend monitoring the feedback, if you thought to yourself, well, that sounds like a lot of time, well-trained staff can do this for us. Not just staff, trained staff. I caught when Dr. Yeager was talking about his experience with this, he said, when my nurse sees, and I hope you picked up on that also, because we can have our trained staff doing this for us. And yes, that was very clearly the intent by CMS when they changed this to general supervision. Direct supervision means doctor needs to be in the building supervising. General supervision means doctor needs to be overseeing the operation, but doesn't even need to be in the building. So if you have well-trained staff that you trust to do this, and you have some degree of supervision going on, you don't even need to be in the building. And they can do this for you with appropriate documentation and, again, ensuring that adequate care is being provided, they're properly trained, you're on top of what's going on, you're supervising what's happening. Staff can do this for us. This is tremendous. Start to think about how this works. You get 30, 40, 50, 100 patients running around out in the community with these smart insoles, and you have staff providing this monitoring. This can be a significant game changer for your practice. Most importantly, in the care that you provide and decreasing the incidence of diabetic foot ulcer recurrence by 86%. But now we can start to think about this from the impact to our practices as well. Now, you may note, I hope you did, that I said for every month that you do this and it was medically necessary. And the reason I said that is we have a third code at this level, which represents our monitoring of the feedback, but not having that interactive communication. Because just like any other service we provide, we shouldn't submit the coding for it unless it was medically necessary. So going back to this 20 minutes of monitoring and that live interactive communication, if you have somebody who's doing fine and they don't have a lot of alerts or any alerts and they don't have any problems, and you go a couple months in a row where that communication was, you're doing fine, do you have any questions? Okay, just keep doing the same thing. At some point, that interactive communication is no longer medically necessary, and they may not want to pay for that interactive communication. So if that situation presents itself, we have another code option, which is CPT 99091, which represents our monitoring of the feedback, but not having that live interactive communication. This is just putting it all together, all the codes we just listed on one slide: product, dispensing, monthly provision of the service, the transmission that's going on, and then the last option that we just went through. Now we need to document what we're doing, right? Just like any other service we provide, if we're going to submit coding for monitoring of that feedback and communicating with the patient, we have to document what we monitored, what we saw, what happened in that communication. A good system that helps with efficiency, I suggest, should provide us with a dashboard where it's all done for us, and then we can just beam it into the EHR. The example that Dr. Yeager and I used tonight with these smart insoles has that dashboard where it gives us the printout of the parameters, the analytics that were monitored, the information that we got, what actions were taken, did we communicate with the patient, how much time was spent in doing this, what interactions did we have, and if there was supervision going on. And then this can be incorporated into the electronic health record. We mentioned the general supervision thing. Again, similar to the DME program in the office, you have options. You can, if you wish, do it yourself, or I would suggest it's much more efficient. And if you have staff that you train, that you trust, you can outsource it to them. There are even third parties that you can outsource this monitoring to, where they function as your trained staff. And there's options as far as getting these products delivered to our patients, which has been a really nice option during COVID. I rushed through that last slide or two because I saw we were coming up on our Q&A session, and we wanted to be sure to provide enough time for that. Thanks so much for your attention, and I will transition it back to Dr. Lockwood to lead us through our Q&A session. And at the risk of repeating what Dr. Lockwood's going to say, don't be bashful with your questions. We hope we get some good provocative questions.
No, I appreciate that introduction, and thank you to both yourself and Dr. Yeager for the fantastic presentation. I'm sure our attendees learned a lot. I know I did. It's good re-emphasis for me about prevention. We appreciate you taking the time to educate us this evening, so thank you both. Also, thank you to everyone who's attending this evening. I have been monitoring our questions, and I'm excited to see that there's quite a few colleagues that I know who've been listening in and commenting. So with that, please, again, like Dr. Lehrman said, don't be shy. If you have questions or comments, please use that questions area located on the side control panel. And again, we invite you to stay for the duration of the Q&A session. However, once you've been online for 60 minutes, you don't have to actually stay for the full duration if your questions or comments have been answered or addressed. Okay, so let's dive into it. We've got quite a few, you guys. Several of them you've already addressed, so I'm going to kind of skip through. But one, and this is kind of unique, doctor says, I'm a board-certified podiatric surgeon, also a podorthist and orthotic fitter. I believe in a 10-second answer. What could his role be in this prosthetics and orthotics in this new technology? I mean, that's basically the entire presentation.
Yeah, so Dr. Yeager, I'll take this one, or at least go first. You, doctor, have the ability to do both. Now, most podiatrists have the training and expertise to do the inserts in the shoes as well, using the example we go through. But what you can do is you can mold the patients for the inserts. You can, if you're doing DME, you can send out for them. You can dispense shoes along with inserts, and then you can engage in the exact remote physiologic monitoring program that we described if you feel that would benefit your patient population.
I agree,
Great.
Jeff.
Thank you. Second one, there's a doctor that's talking to us being from Ohio, and he's noticing that Medicare is currently denying the RPM codes. Any concerns or anything you can address? I know that could be specific to his LCD, but anything you can address with that with someone from Ohio?
I'm going to go first with that too. Sorry, Dave, because it's a paying thing. The first thing is there are some third-party payers that incorrectly interpreted these remote physiologic monitoring codes at first. And if you don't know, CPT makes the codes, right? The payers, Medicare in this example, they have nothing to do with the creation of the codes. CPT makes the codes and then sends them out to the world. And when the codes were created, you will notice if you look at the, actually, you know what, I'll go back. If you look at the descriptor for remote physiologic monitoring, it says EG, for example, and then there were some examples listed there. The examples that were listed all happen to be systemic things. And there are third-party payers who have made the mistake of thinking it must be one of those things in parentheses. Maybe they don't know what EG means, or maybe they want to pretend they don't know what that means. Dr. Lockwood shared in my introduction that in my APMA role, I get to attend the CPT meetings. That was not the intent when these codes were written. It was just meant to give an example. That is, it is not all inclusive. So some of these payers have required some education about exactly what these codes are intended to represent and which provider types can perform these services. There have been 3, I think, of the 7 Medicare contractors that have completely shifted gears on this, and they get it. They just required some education. Ohio, to the doctor in Ohio, you probably know you are in the smallest Medicare jurisdiction in the country, having only 2 states, and it might just be that this hasn't come on their radar yet. ASPS is an affiliate of the APMA, being the surgical affiliate of the APMA, so I feel comfortable promoting APMA a little bit. Hopefully you're a member, and if you are, you know that your Ohio State Association is phenomenal with advocacy things, and if you're having trouble, I suggest that you report this to your state association, and they can get the national association involved if necessary, but Ohio's pretty awesome. And if you're having any trouble, I suggest you report it to the state, and they should be able to help you.
You know, and I agree, Jeff. I mean, kill them with kindness and dazzle them with facts. And as long as you provide the data that we've provided through this entire presentation, I don't see how they can deny the fact is that the numbers don't lie. This is effective, and the efficacy of decreasing the amount of DFUs in my practice has been tremendous. So send them as much information, send them volumes, send them the random control studies, do that and educate them. And you hit it right on the head, Dr. Lehrman. Sometimes you have to educate them because this is new technology. But take it easy, take a breath. They'll understand once you show them the numbers and once you show them the benefit and the dollar amounts that they're going to save.
Great, thank you so much for that answer. This next one is a comment, just adding on to Dr. Yeager's commentary from earlier that tissue ischemia can even occur after just 2 hours of continuous pressure, and then you were complimented to keep up with the great lecture. The next one was a question about staff time. Actually, we've got several questions about staff time, so I'm going to kind of combine them. Can you two touch on whether or not, number one, is it compliant to use a third party to do this monitoring for you, like if you hire this out? And number two, and I really liked this question, that initial 99453, can trained staff perform that?
They can. And this was awesome. So the first year we got these codes, us doing this, and they want to clear the pathway to get this to their beneficiaries. So for the
Dr.
change
Lehrman,
from 19...
I apologize for interrupting you for just a moment. If you can go back about 15 seconds, we lost your audio for just a moment. I'm so sorry.
Sorry. I was saying that when these codes first came out in 2019, it was direct supervision. In 2020, it was changed to general supervision. The cool thing is that didn't even require a lot of advocacy or asking for that. CMS did that on their own, and that supports what I said earlier, that they want us doing this. They wanted to clear the pathway for our ability to do this, and they switched it from 2019 being direct supervision to 2020 being general supervision. How often does CMS make it easier for us to do something? How often do they decrease restrictions, which is exactly what they did here, which supports my point I made earlier. They want us doing this. So yes, this one can be performed under general supervision, which means trained staff can do this. I'm being picky in saying trained staff because it's important, right? We want to make sure they're doing it right. It's a risk management standpoint. I would suggest a formal training go on where you document that they've trained. It could be a C1, do one, teach one situation, right? Some sort of formal training going on. And I'll note that this one's general supervision, so is this one, and so are the 99457 and 99458 codes. Yes, trained staff can do this, and makes a big difference when you want to implement this into your practice.
You know, and I agree, Dr. Lehrman. I'll actually go in and co-sign my nurse's note to make sure that I've looked at that from a medical legal standpoint, and then discuss it with her in terms of, you know, what's going on with Mr. Smith, and you know, do you think he needs to be seen? And so it's all inclusive for the benefit of the patient, and really establishes a nice dialogue with your staff.
Great, thank you both for those. Now, the next couple of questions kind of all relate to the specific RPM devices and even some questions about that. So the first one is, and I believe I know this answer, but is there a sample consent form as you are kind of going through the process of discussing these options with your patients? I believe that's on their website, but can you clarify?
Yes, the companies that provide the devices that provide the feedback, they want us doing this. They want to provide us with the tools to streamline it. And I think you'll find when working with the company that knows what they're doing, they can help you with templated forms like that.
So, Dr. Lehrman, can I ask a question?
Of course.
Cool. So, there, you know, there's a little kind of a two-part question that Dr. Lockwood alluded to a little while ago in terms of, can we have a third party being able to contract to do this? Have you seen that?
Yes, absolutely. Yes, we can. That's part of the general supervision thing. In that situation, they're kind of functioning as, well, so for the, if it's our, let me rephrase that. If it's our trained staff, yes, that's the general supervision. We also, if we don't want to deal with the monitoring, if we don't want to do it, if we don't want our trained staff to do it, and we're not worried about these codes, and we just want the service for our patients, the whole deal can be outsourced to a third party to have them do the monitoring for you. That is an option if you wanted to outsource that. And yes, that's gone under legal review to make sure it's compliant with the guidelines. Yes, we can have a third party doing it for us.
Great, thanks.
Thank you. So we've gotten several comments and questions, and I'm just going to say in general that I agree with all of our colleagues when they say this, but the consensus is, you know, I'm going to highlight one. The vast majority of the patients that we see are non-compliant, irresponsible, and questionable on their compliance. How dependent are we on our patients to do this properly? And that is actually a question that I'm seeing over and over again as we address this. I think that we all have just some skepticism and concern with respect to that compliance. So if you guys can both address your experience with that compliance issue with your patients over this past year.
Well, I can tell you this, that when I do a note on a progress note, I put in the subjective. If a patient tells me something that either is positive or negative towards their result, I put in quotations and direct quotations. And so when they come back and they say, well, you know, I'm in so much pain, or I don't know what happened. Well, according to this note on July 11th, you said, and I quote, and I show them the note, and they're like, it blows them out of the water. And so this actually enables me to have another form of armament to show the patient. Now, you know, I'm not talking about a war with these people, okay? What I'm talking about is establishing a relationship and a dual responsibility for your health. And if we give them an opportunity to look at these things and make it exciting for them, because, you know, when it comes down to it, you know, they really think, oh gosh, I've got another ulceration, or I've got something in my bag that can prevent it. And so I like to put in their chart, like, you know, Dr. Lehrman alluded to, and I'll go back and show them, and we'll go back a couple months and I'll say, listen, this is where you were at 2 months ago. This is where you're at 3 months ago. And, you know, I'm primarily going to see these patients too, you know, for even diabetic nail care, which, you know, I do total ankle implants, but I'm not above doing nail care because I love that opportunity, if they're using the insoles, to educate them, to talk about some things, to get to know their family, and that reestablishes the trust that I need within my relationship with my patients.
And to build on that, this, you know, this discussion of the patients not good listening, non-compliant, whatever, that is not we can't use that as an excuse to not provide the very best care available. Having done some risk management work in defending our colleagues, saying I didn't offer it because I knew the patient wouldn't use it right, jury does not want to hear that. That does not work. If there's something awesome that's available that could help somebody that could have prevented a disaster, our failure to provide that as an option and using the excuse that they don't listen and they wouldn't use it right anyway doesn't work. And this might be a little soapboxy, but maybe it will help because all of us deal with this, you know, concept of the patient's not doing what we want them to do. A lot of it's on them, no question about it. But we have some more recent peer review literature that shows that the same small vessel disease that gets their foot also gets their brain. And there's literature that shows diabetic patients with foot ulcers have a higher degree of cognitive impairment than those without foot ulcers, which supports the same small vessel disease that's happening distally is happening in you know, impacting their brain. So some of it is, yeah, them being stubborn and they want to work and not listen and not wear their boot or whatever. But some of it's, you know, it's hard for them, and some of it's on us too in providing the education and doing better than keep your sugar good, which means nothing to them, right? Providing them with the information and arming them with what they need to actually keep their sugar good, because they have no idea how to do that, right? And saying you have a better chance of keeping your foot if your sugar where it belongs, they don't know. Most of them, they don't know how to do that. And there's a lot more education that many of these people need to even give them a chance of following the directions that we want them to follow.
And you know what, Dr. Lehrman, you hit it right on the head. You know, I spent at a patient where I was going to do a show parts amputation with an intramedullary rod. I went through a half an hour conversation. Do you know what that patient asked me? Take a guess. He asked me, he goes, so when's dinner?
Oh my gosh.
So, you know, it's comical, but it's also very sad in terms of, you know,
It is
direct commentary on some of these diabetics. And, you know, yeah, he's gone through several surgeries, but, you know, sometimes we could beat our heads against the wall and we're just not going to get to them. And so this enabled us to have an opportunity to empower the patient to take some responsibility.
Good, thank you. And I think that was very encouraging, both of your commentary when it came to that. Okay, so I've got a series of questions that talk about the inserts themselves, and specifically, and this was asked over and over again, you know, are these inserts specifically ones that you can add things like a layer of plastizo to? Can we do pocketing if there's already an ulceration or a pressure point? You know, how custom are they? I mean, we're getting quite a few questions just about the structure of the inserts themselves.
Well, I'll take that one, Dr. Lehrman. I mean, you know, hopefully that they never develop the ulceration for the insole itself. However, I find, and once our audience is able to feel the insoles themselves, they are very thin. They're not obtrusive to the shoe itself. And I think one thing I would stress to these patients is that you have to take your existing insole out, okay? I come in and I have patients that have the insole still in there. So they need to take the insole out. It is accommodative in terms of if I need to add some padding, but you got to be careful because you don't want to ruin the technology and that's associated with this. I probably, if they develop an ulceration, I'm not going to keep them in the insole because number one, if it's bloody, if it's infected or anything like that, I'm going to take them out of it, okay, and do some off weighting, some advanced wound modalities, something like that. So my fear is that they come in and they've already had an existing ulceration that they didn't feel, and now they've ruined a pair of insoles. And so fortunately, I haven't had that yet, but I think that's on the horizon. So answer your question, I'm going to move them out of the insole and completely take them out of them so that they don't ruin them and be able to accommodate some of the things that I'd like to do with that plantar aspect of the foot.
Okay, thank you. So, and then following up on that, because we are all very well versed on how Medicare reimburses for these different things, just to clarify, so if in 2021, if a claim has been paid for, let's say, an A5512, so 6 pairs or 6 inserts of the heat moldable inserts, will Medicare also pay for an A5514 in 2021? And I've got several follow-up questions after you've addressed that.
No. I left enough time for follow-up.
I went back on mute too fast. Okay, thank you for the no. Does the A5514 reimbursement at least cover the cost of the devices themselves? Because they are asking some very specific questions about reimbursement and cost of the inserts themselves, and even if you can recommend any specific ones you would want to suggest.
So we're outside of our 1 hour CME. So yeah, we can speak
Correct.
to that.
That's why I waited for those questions. Yes, sir.
Especially answering the direct question. Orpyx sensory insoles is the branded name of the example that Dr. Yeager and I went through tonight. And heck yeah, you profit on the A5514. Absolutely.
Thank you. I was waiting for that question. And one more comment when it comes to the actual coding of it. It's just like diabetic inserts A5512 or A5513 in the past, where you would just do KX and then RT and then the second line KXLT, correct?
That's correct.
Okay. When you document 99457, is it sufficient to simply state 20 minutes spent reviewing the note in the dashboard?
No. No, it's not. We should be documenting what we reviewed, what we saw, right, and what we did about it. But let me go back to the dashboard. If the feedback that's provided by the dashboard is incorporated into the progress note, maybe I should have been more clear. Instead of saying into the EHR, into the progress note that goes with the date of service of 99457, then it's a yes. So let me repeat that. If the information provided by the dashboard is thorough and complete, and it's in the progress note that has the date of service that corresponds with the date of service of the 99457, then it's an absolute yes, because then you have everything in there. We don't have to write it. We don't have to type it. We are allowed to beam it in, but it does have to be part of the progress note. And I know that's lame. It can't live somewhere else within the EHR. It should be in the progress note. That's the most thorough approach, because in the worst case scenario, when an auditor comes to check out a 99457 and the date of the 99457 is April 1, they say, give me your April 1 note. They don't see, let me look through the entire record. They just want April 1.
Understood. Okay. Just for clarification, there was a question that I know that I can address here. Will our codes and the lecture be available for review after the lecture? And that is yes, this recording will be placed on the ASPS, on the backside for members. So I wanted to address that really quickly. So back to reimbursement again, Dr. Lehrman, sorry about that, but we're getting questions about average reimbursement versus cost, and you know, specifically for the devices themselves, for the hardware, for the smartphone itself, and then the monthly service fee that we are getting reimbursed for. So we are the cell phone company. Can you address that just in general terms? I know specific to the different MACs, but we're getting a lot of questions about it.
Yeah, you profit on all of these. The cost to provide the transmission monthly is less than the reimbursement that you get from the 99454. To look up the dollar values differ too much around the country. It would be irresponsible for us to give out dollar values. You should know what your fee schedules are. You shouldn't be working blind and not knowing what you're getting paid for stuff. If you want to look at the Medicare fee schedule as an example, you should know which Medicare jurisdiction your state is in. If you don't know that, you should. There are 7 Part B Medicare contractors. 7. If you don't know, you can just Google which state is in which Medicare jurisdiction, find out who your Medicare contractor is, and all of them have the fee schedules on their website. A lot of people, they don't know this, and they think like it's hard to find or it's a secret. It's not. No passwords, no nothing. Anybody in the community can just go on the Medicare contractor's website and look up your Part B fee schedule and see exactly how much these pay. And then as far as cost, that's going to differ based on the company that you are affiliated with, who you're using, and what your purchasing agreement is with them. So we gave the example of Orpyx. You can reach out to them. They'd be more than happy to quote you costs associated with this.
Okay, thank you on that. And I know as people are putting in more questions that they're still just asking things about, is pre-certification necessary prior to this? What are the parameters for medical necessity, which I'm assuming is very similar to when you're participating in the diabetic shoe program. Yeah, you can address either of those things. I don't believe pre-certification is necessary. And
yeah, in short, Medicare has we're starting to get beyond the scope of the presentation here. Medicare
correct.
has a very short list of services that require pre-certification. This is not on there. Private payers, I recommend pre-certing almost everything. So it depends. The answer is it depends on the payer. For Medicare, no.
Okay. And then just to re-clarify, because I heard you say this earlier, but there was some question in the chat. Third-party payers are also reimbursing for this, but it is sporadic. Is that correct?
I'm not aware of it being sporadic. If there's a third-party payer who's not paying, I would suggest the same guidance that I provided to the Ohio attendee tonight. That's going to require some advocacy and education. There's no reason why they shouldn't be paying. The codes are there. Medicare has them on their fee schedule. The medical necessity is there. The literature is there to support the service. If they're not paying, they should be educated, like Dr. Yeager said.
Okay. And then there was just a question about the clarification of the coding from the hardware's perspective of A5514. How do the smart insoles qualify as A5514 versus any other potential insert types? I think that's what they're trying to ask.
If you look at the slide that we're showing right here, you can see the definition of A5514. The smart insoles that we used in our example tonight meet that definition of A5514.
Perfect. And this is a good one. So what are some other examples of remote monitoring systems that would be available to podiatrists? I realize this was sponsored by having the opportunity to talk about smart insoles, but would there be other examples that you know of, Dr. Lehrman, that would be something that podiatrists could monitor?
Dave, I'm going to ask for your help on this one. There's other stuff out there. It might just be that I don't know, maybe because we've been trapped in our houses for a year and I haven't gotten to walk around trade show halls, but I am not aware of any other options that meet all the requirements. That's an important point. There's other options out there. I'm not aware of any options that meet all of the CPT and third-party payer requirements.
And to answer your question, Dr. Lockwood, you hit it right on the head, Dr. Lehrman. There are other out there. I do not use them, so I cannot comment on them.
Okay, thank you. This is I think just to clarify, does Medicare recognize this or allow for it for patients who have idiopathic neuropathy without diabetes? I don't believe that's the case, correct?
Yes, there's no assignment of which diagnosis codes can be used with this. As long as the medical necessity is there, it is considered to be medically necessary and therefore payable. So it's on us to determine that medical necessity in our documentation. I think we could all agree from a clinical standpoint, a non-diabetic with profound neuropathy is at the same, well, I don't know, pretty much the same risk as a diabetic with that neuropathy.
Agreed. Yep, absolutely. But it's no rhyme or reason it sometimes, correct?
Correct.
So 2 more questions. What are who qualifies for having a sensory insert? Does you have to have an ulcer history, or is it you have to have diabetes? Like, can you kind of elaborate on that just a little bit?
Yeah, I'll take that one, Dr. Lehrman. I see every patient as an opportunity if they have proven diabetic neuropathy to me. And then even the patients that are pretty sensate or newly diagnosed, I'll run the technology by them just to kind of plant the seed. But I don't think there's any diabetic out there that should not receive some type of monitoring system out there. Because like I alluded to it in kind of throughout the presentation, it really boils down to saving lives, quality of life, and the economic standpoint of saving us money, because right now healthcare costs are raging out of control. And so I think that from a perspective of patients that qualify, each and every diabetic that walks in my office is an opportunity for them.
Okay, I've got one more only because it's been asked about 3 or 4 times in the last 3 to 4 minutes. Is there any concern, and I don't believe that there is there any concern if you're having a patient come in for their diabetic nail care on that date of service, or perhaps you're seeing them for a separately identifiable evaluation and management? Can nail care codes be billed to Medicare on the same day that you would dispense to DMARC? And I believe I know that answer is yes. And then
he's the pro on that.
Right, exactly. I'm like, I believe that's the case. I'm quoting him as I'm talking about separately identifiable evaluation and management. But that's the other question. Can you bill 99213 and 99457 on the same date of service?
No, because those 99 codes are
Correct.
E&M codes. So we can't do 2 different E&M types at the same time.
Correct. Thank you for clarifying that. That was just asked several different times. But these were great questions this evening, and I want to thank you both again so much for an amazing night of education. Everyone, please check your emails for upcoming events offered by ASPS. We really wish you all a pleasant evening. Thank you again, and good night.
Thank you, everyone. Stay safe.